This video has been funded through an educational grant from Biocon Biologics Limited. Biocon Biologics Limited has no input towards the content of the interview or the video. Now in its 47th year, the 2024 San Antonio Breast Cancer Symposium, or SABCS, featured over 2,000 accepted abstracts and representatives from over 100 countries. Professor Nadia Harbeck spoke with us following the conference to highlight presentations that have practice-changing implications today and promise for the future of breast cancer care. We started with updates from the TAILOR-X trial.
TAILOR-X is one of the prospective trials looking at oncotype DX in early breast cancer and the Nummulan-like disease setting for the question whether we can use gene expression assay to avoid chemotherapy. TAILOR-X has been published several times. They have 12-year follow-up showing that in the intermediate risk group with an oncotype between 12 and 25, there is no additional benefit from chemotherapy in postmenopausal patients in all of N0. TAILOR-X is just in 0 patients, and there is maybe a little bit of benefit in premenopausal patients already starting from a recurrence score of 20 onwards. The analysis that was presented in San Antonio 2024 was a post hoc analysis looking at the impact of anthracycline containing chemotherapy in patients with a high risk oncotype. And what the investigators found was that apparently, if you have a recurrence score of 20, no, of 31 and higher, that there is benefit from anthracycline containing versus anthracycline free chemotherapy. The chemotherapy patients for this post hoc analysis came from the standard arm, from the ones that were randomized to chemotherapy in the recurrence score range 12 to 11 to 25, and from the high risk population. The chemo wasn't part of the protocol, so the centers used whatever they were using for their patients, and there was about 6,000 patients all together, but about 2,500 for this particular analysis. So basically, the bottom line is the higher the recurrence score, the more evident is the benefit from anthracyclines versus no anthracyclines. Having said all this, we didn't find the same thing in our WSG Plan B trial, where we had the chemotherapy as part of the study. So it was a regimen of 6 cycles of TC versus anthracycline taxane sequence, and we did not see that recurrence score was predictive for benefit from anthracyclines in patients with node negative and node positive disease. So I'm not so sure that we definitely need to use anthracyclines in high risk recurrence score patients. But I think what the study from Chen and all tells us is that we definitely need to use standard and optimized chemotherapy regimens, because they had a very nice analysis showing that also CMF or 4 cycles of AC were not as good as the anthracycline taxane sequence. So with regard to the anthracyclines, we have differing data from the West German study group Plan B study, but overall, I think high risk recurrence score means high clinical risk. And today we also have CDK4/6 inhibitors available for that population. So the anthracyclines are not going to be the only therapy the patients are getting.
What reasons might there be for that difference?
I think it's because the Plan B trial was a chemotherapy trial, so we had defined chemotherapy regimens. We were not comparing like a basket of different regimens. And maybe in the TAILOR-X trial, there was only 4 cycles of TC used, which is also a substantially shorter chemotherapy versus a longer anthracycline taxane sequence. So maybe the apparent benefit they're seeing from the anthracyclines is actually also a duration effect of chemotherapy. I'm not sure. I haven't seen a publication yet. It wasn't well explained in the slides that we saw at San Antonio, but I think it's a community practice chemotherapy use, and that's not the same as a randomized prospective trial. So that's maybe why we didn't see the same predictive effect. But I take the data very seriously, and I think what they're showing us is that you have to use optimal chemotherapy in those patients.
Could you summarize what was presented from the ADAPT trial?
Yeah, I mean, that's very dear to my heart. ADAPT is part of our West German group's study trials, and ADAPT is actually a very large trial, which we've presented several times in San Antonio. And this time it was the final analysis presented by my colleague Sherko Kümmel. And uh, I think there is two messages from the ADAPT presentation in San Antonio. The first message is just the patient flow chart, where he showed that we recruited about 5,600 patients for the ADAPT, and then with an algorithm of Oncotype DX as well as a short preoperative endocrine therapy before surgery, we sort of put patients in the endocrine trial or in the chemotherapy trial ADAPT. And the endocrine trial was patients with up to 3 lymph nodes, recurrence score up to 25, and good endocrine response. That is a Ki-67 after this short preoperative endocrine therapy of 10% or less. And those patients were able just to get endocrine therapy versus the Ki-67 non-responders, as well as patients with a high-risk oncotype or with a substantial nodal burden of 4+ lymph nodes. They were randomized in the chemotherapy cohort. And the first message is from all of those 5,625 patients who had clinical indication for chemotherapy, and then had this algorithm of Oncotype DX and endocrine response assessment, we were able to not give chemotherapy in 44% of the patients. And these patients, as Dr. Kümmel showed in his talk, did extremely well in follow-up with just endocrine therapy, with a IDFS of about 93%, independent of menopausal status, and even um, distant disease-free survival of about 97%. That is patients with up to 3 lymph node, recurrence score less or equal to 25, and endocrine response. That's the first message. So you can select patients if you use endocrine response assessment together with Oncotype DX. You can spare more patients from chemotherapy than just using the genomic assay. The second message was the evaluation of the chemotherapy comparison in the chemotherapy cohort. And here we had 2 dose dense regimens with either nab-paclitaxel on a weekly basis or paclitaxel on a 2-weekly basis, together with dose-dense anthracyclines. And basically, the bottom line here is there was a slight difference regarding this disease-free survival or IDFS favoring nab-paclitaxel. But if you look at the very important endpoints for patients, distant disease-free survival or overall survival, there was just no difference between the two taxanes. So um, in Europe, we don't have a registration for nab-paclitaxel in the early breast cancer setting, but we can use it if in patients who have allergic reactions to paclitaxel. So, and I think the ADAPT data confirm that both of these taxanes are very good agents in the early breast cancer setting.
What was the update to data from the Olympia trial?
I think we all know Olympia by now. It's the adjuvant olaparib study in patients with a BRCA mutation, and patients could be um, either TRPR negative or luminal breast cancers. And so all of them had HER2 negative breast cancers, and we now have an overall survival benefit with olaparib of about 4% at 6 years. And that's independent of the hormone receptor status. And I think nicely shows that this is a valuable addition to our adjuvant therapy. And it's not practice changing because we've implemented that earlier with the first analysis of the overall survival data, but I think it's very reassuring. And I think there was one point in the discussion, in the talk, that is really important, is that we don't have more hematological toxicities with this 1 year of olaparib. We were all afraid we're going to have more MDS or more AMLs, and that couldn't be shown. The rates are low. It's below 1% in either group, and actually numerically there is 2 more in the placebo group, 6 versus 4, but overall a very low hematological toxicity. So I think we can conclude from that presentation that olaparib improves overall survival and is safe to give for 1 year.
And lastly, the highlights of the Patina trial.
Yeah, Patina was actually unexpected, wasn't in the program. They added it last minute, and I think it's a very visionary trial, but it's very low hanging fruits because it's something that we should have done much earlier. And basically, what the investigators did was they took the first line regimen for a HER2 positive metastatic breast cancer, which is a taxane plus dual HER2 blockade, trastuzumab and pertuzumab. Um, they also allowed vinorelbine as the chemotherapy backbone. And then patients usually get 6 to 8 cycles of chemotherapy, and then we do maintenance therapy with the antibodies. And this was a population of hormone receptor positive, HER2 positive metastatic breast cancer. So the standard maintenance would be the antibodies plus endocrine therapy. And in this trial, they randomized 1-to-1 to add palbociclib, so a CDK4/6 inhibitor, to this endocrine maintenance therapy together with the antibodies. And the results were stunning. I think we've never seen such a good progression-free survival. It was 44 months median versus 29 months in the control arm, which is also very good. And the median follow-up was almost 6 years, 52 months. So I think this is data that is immediately practice changing. Unfortunately, we don't have our approval for palbociclib in this setting. So what we need to do probably is to apply for reimbursement on an individual patient basis. But I think having seen the data, it's really worthwhile doing that. And there's also a trend already for overall survival, although very very small difference so far numerically between the two arms, but it's going in the expected direction. So yeah, I think the data is great. The toxicity, additional toxicity, is very manageable. We all know how to manage palbociclib, and I think it's something that we should have done earlier. And where we also have other data, we just saw at ESMO last year, the DETECT 5 study presented by Dr. Wolfgang Janni from Germany, and he showed that the addition of ribociclib to a endocrine um, combination with dual HER2 blockade actually is very good and beneficial for patients compared to endocrine therapy alone, and that this combination is also um, not inferior to a chemotherapy based antibody combination. So I think with all of these data points coming together, we're probably going to look more at the triple positive, the HER2 positive, hormone receptor positive population um, differently than we've done before, where we gave chemotherapy to everybody. So I think great data, immediate practical input. The only downside, or a downside if you want, probably just because we don't know what we're going to do in half a year's time, is that we're going to see at ASCO the first line data for TDXD versus the standard Cleopatra regimen in that setting. So I think then we have to sort of readjust what we're doing in first line, second line. But I think the message from Patina is very clear. If you have triple positive disease, adding palbociclib to endocrine therapy together with the antibodies definitely improves outcome.